In this module on workplace safety and wellness, we will look at the proper lifting and moving of patients. Once completed with this module, you should be able to differentiate proper from improper body mechanics for lifting and moving patients in emergency and non-emergency situations. Just because you are studying to be a paramedic does not mean everything you learned in your previous EMS education and training is no longer useful. As a matter of fact, everything covered within this particular module is simply a restatement of what you have already learned in your initial EMT class. The proper mechanics and guidelines for lifting and moving patients still applies to the paramedic provider as it did when he or she was an EMT or AEMT. As a result, this particular module will not go into a great deal of depth. Refer to your previous EMS educational materials for additional information if necessary. To begin our review of lifting and moving patients, we will discuss proper lifting techniques. Unfortunately, back injuries are prevalent in the EMS profession and constitute a significant injury risk to EMS providers. According to NIOSH data published in 2017, more than 22,000 EMS workers visit emergency departments each year for work-related injuries, and of these injuries, most are sprains or strains that occurred to the back and neck given body motion precipitators such as excessive physical effort or awkward posture. Thus, it is important to follow some simple safety precautions and lifting guidelines when lifting and moving patients. Before lifting or moving a patient, first ensure you have enough personnel available to safely lift or move the patient by considering the physical abilities of the EMS providers on scene, along with not only the weight of the patient, but the surface over which you will be lifting the patient, along with the distance the patient will need to be moved. If you are on a two-person ambulance crew and need to lift or move a 300-pound patient over uneven terrain, it would probably be wise to garner additional help from another crew, firefighters, or even the police. Be sure you have proper footing and always follow principles of safe lifting through proper body mechanics. Do not move the patient any further than necessary. Use equipment to help with the lift or move if available. Bend at the knees, not the hips, to squat down and subsequently lift the patient. Try to keep the patient as close to your body as possible when lifting. Be sure to communicate with each other while performing the lift or move. You want all EMS providers and other helpers to lift and move at the same time in concert with each other. Whether you are lifting the patient directly or lifting a cot or stretcher with a patient on it, these same guidelines apply. As far as proper lifting mechanics are concerned, many training centers teach EMS students how to use a power lift or squat lift to lift a patient. The two techniques are very similar with some minor variances. In a power lift, you place your feet a comfortable distance apart with the feet turned slightly outward before bending your knees to lower your body close to the patient. If done correctly, you will feel as though you are sitting down as opposed to bending over. From this position, you should straddle the object or patient to be lifted with your weight evenly distributed between both feet. Your hands should be placed on the object or patient to be lifted at a comfortable distance from each other that allows you to maintain lateral balance of the object or patient. Contract the muscles of the back and abdomen to essentially self-splint your own spine. Keep the back straight and close to vertical with your head facing forward in a neutral position, and drive up through the heels and arches of your feet by straightening your legs. If it helps, think about stacking your shoulders on top of the hips and the hips being stacked on top of your feet. You want the shoulders, hips, and feet aligned in a vertical plane, up and down, so that the forces associated with lifting a patient or object is transferred directly into the ground. The more your spine is deviated from this vertical plane, the more risk you are for a back injury. The squat lift is similar to the power lift, with your feet staggered a little with one forward or in front of the other. For providers with a weak side or leg, the weaker leg is slightly forward and that foot remains flat on the ground, while the stronger leg is shifted slightly back to allow the provider to push up with that stronger rear leg to lift the patient or object. Again, regardless of the lift being used, do not bend at the waist. Bend at the knees, keeping the spine upright and as vertical as possible. Use the muscles in the legs, not the back, to actually perform the lift and keep the object or person being lifted as close to the body as possible. When grasping items that you are lifting or moving, the cot or stair chair in particular, many refer to the use of a power grip to maintain maximum grip force throughout the lift or move. This grip is one in which the provider's palms and fingers are in contact with the item or person being lifted, with all fingers bent at the same angle. Another important aspect of proper lifting and moving mechanics is the recognition that the risk of back injury increases as the provider twists or turns. Thus, when lifting or moving a patient, providers should attempt to keep their back in a locked-in position. This means not only keeping the back upright and as close to vertical as possible, but also preventing twisting and turning of the back. Lift straight up and down without rotating the back or chest. Lastly, if you are lifting a patient on a piece of equipment, such as a longboard or scoop stretcher, ensure the patient is properly secured to the piece of equipment. This is a picture of someone performing a proper squat lift. The person is bending at the knees while maintaining alignment of the torso within a vertical plane. Notice the location of the feet in relation to the thighs and torso. The center of mass for this person is in vertical alignment, and as this person stands up, those points should ideally remain aligned. The person is squatting at the knees while keeping her head and chest up. This is a proper squat lift. In contrast, here is the same person bending over at the waist without using her knees. See how the torso, legs, and feet are no longer aligned? This creates significant stress on the lower back, especially when lifting a weight, as the person must struggle to not only lift the weight, but also maintain her balance at the same time, which can exert even more force on the lower back as the person's center of gravity is already shifted forward by bending over at the hips in this fashion. Do you see how the woman's back is actually humped over? That is yet another indication of bad body positioning and lifting mechanics. Ultimately, this particular type of body positioning is incorrect and has a higher potential for injury. So why do you not want to bend over at the waist? Gravity and physics is why. Industrial hygienists, engineers, and ergonomics specialists often use Freebody diagrams to calculate the forces at work in different routine body movements. In this particular instance, let's look at a subject bending over at the waist. We will look at a plane that is defined by the spine and 2 points, the center of gravity of the torso and the joint between the lumbar and sacral L5-S1 vertebrae. The distance between these 2 points will be represented by the variable d for distance. We will also draw a line down toward the ground representing the weight of the torso, head, abdomen, and arms. This force due to gravity will be represented by the variable w. We must also define an angle between that spinal plane and the weight that is being pulled down by the force of gravity. That angle shall be called theta. As EMS providers, we understand how the body works, and we know that bones and joints do not actually perform work. Rather, muscles are required to move our bones around the joints. The back is no different, as muscles running along the spine, the erector spinae in particular, are responsible for straightening and rotating the back. These muscles are not contained within the spinal column, rather they are positioned anterior to the spinal column. The distance from the center of the spinal column to the center of the erector spinae muscles is approximately 2 inches. The force exerted by the erector spinae to move a person from a bent over to a standing position, denoted here as Fm, subsequently creates a compressive force on the spine, the variable c in this diagram. So let's assume for the moment that this person is an average male with an upper torso, head, abdomen, and arms weighing 75 pounds, and a distance of 15 inches between that center of mass and the L5-S1 joint. We can then use those variables to calculate the force produced by the erector spinae and, subsequently, the compressive force this places on the spinal column as the angle of theta, the degree to which the person bends over at the waist, changes. When the person is standing straight up, theta is 0. The erector spinae does not need to generate any force to lift the torso to that position, and the compressive force upon the L5-S1 joint is the 75 pounds associated with the pull of gravity upon the individual's upper body. As we increase theta, the angle of the bend, however, both the force generated by the erector spinae and the resulting compressive forces upon the back increase. At the point where a person is bent over at a 90-degree angle, the compressive forces on the back are approximately 563 pounds, and this is without the person trying to lift any weight besides his or her own upper body. As you add weight, the forces involved to straighten up only increase. That is why it is so critical to lift with your legs and minimize bending at the waist. The more you bend at the waist, the more force must be exerted by the muscles in the back to the spine in order to stand back up. These forces, especially when compounded with additional movements like twisting, heavier providers, meaning the W variable is more than we included here, a lack of good physical conditioning, and lifting the additional weight of a patient or a piece of equipment can all result in back injuries to the provider. When lifting a longboard or a patient, the same type of squat lift position should be used. Notice how the weight to be lifted remains relatively close to the woman's center of mass. This is very important, as the further away the weight to be lifted is from your body, the more force it takes to lift the weight, which puts additional strain on the EMS provider's body. So let's look at the science again. When lifting a weight, the math becomes a little more complicated because we need to consider the horizontal distance between the L5-S1 joint and the weight being lifted. To make things simple, let's look at only the forces necessary to lift the weight of an object, and we will also assume the provider is standing straight up and down without any bend at the waist. That gives a theta value of 0, which simplifies the equations. For the purposes of our calculations, we will use a weight of 50 pounds for the object being lifted, which would be pretty light for a patient, but let's go with it. At a horizontal distance of 10 inches from your L5-S1 joint, the compressive force on that joint when lifting 50 pounds is 300 pounds. Double the distance and the force required of your erector spinae to lift the weight doubles, resulting in 550 pounds of compressive force. Tripling the distance means the muscles in your back must work 3 times harder, increasing the compressive force on your back to 800 pounds, all for a 50-pound weight. Remember as well, that does not include any bend at the waist, and we did not include the weight of the person's arms. Right now, we are looking only at the weight of the object itself. Add a bend at the waist and include the weight of the person's torso, head, and arms, and the compressive forces on the spine would only increase as the muscles in your back must lift not only the weight, but your upper body, head, and arms as well. In brief, that is the math and physics behind the need to keep anything you lift, especially patients, as close to your body as possible. The further away from your body an object is held, the more energy you need to expel to lift it, and the more force and stress it puts on your back. Once you lift or pick up the patient or object, in many cases it is necessary to then move that patient or object. When carrying something, whether that be a patient, a piece of EMS equipment, or something else, many of the same precautions related to lifting apply. One additional consideration that comes into play when carrying an object or person is to be aware of the terrain over which you will be carrying or moving the person or object, and be careful of your footing. Carrying or moving over flat, dry concrete is typically not as perilous as carrying or moving over uneven, slippery, or shifting terrain. When carrying or moving an object or person, the EMS provider wants to keep his or her back in a locked-in position. Do not twist at the torso or waist if you can avoid it. Also keep the weight as close to your body as possible. As we just discussed in the previous slide, the further a weighted object is away from your body while carrying it, the harder it is to carry the object and the quicker muscle fatigue sets in. When moving patients, doing so using a wheeled cot or stretcher is preferred to limit stress on the EMS provider's bodies. Given the nature of providing EMS in all sorts of environments, however, using a wheeled cot or stretcher in all instances for patient movement is not always feasible. In such cases, it is a best practice to use a longboard, scoop stretcher, basket stretcher, or some other piece of equipment to assist with patient movement. When moving a patient in such a fashion, it is important to ensure you have enough providers available to carry the patient safely. As the weight of the patient increases or the terrain becomes difficult, more providers are needed. It is also a best practice to have an even number of people assisting with such a carry to help ensure the team keeps the patient balanced. Before the patient is even lifted, make sure he or she is adequately secured to the board or stretcher with at least 3 straps. It may also be necessary to secure the patient's hands so that he or she does not reach out while being carried by the EMS providers. If going downstairs or a hill, the patient should be carried feet first. Inversely, if going upstairs or a hill, the patient should be carried head first. Take smaller steps if necessary, especially over difficult terrain. Be sure to maintain your posture, keeping your shoulders, hips, and feet in alignment. If the terrain is extreme, it may be necessary to seek assistance from a specialized team, such as a high-angle rope rescue team or maybe even a helicopter evacuation team. Communication is very important, as is the need to have a firm grasp of the board or cot with a power grip. If you become fatigued or feel as though you are losing your grip, communicate calmly to your team and request assistance or ask to safely lower the patient so that you can readjust your grip or regain your strength. If you find yourself in a position where you need to walk backward, having a crew member available to spot you is another best practice. Sometimes it is necessary to lift and carry with a single hand. When lifting, rather than squatting down equally over both feet, it is more common to have your feet staggered with one knee up and one knee pointed toward the ground. If done correctly, you are still bending at the knees, not the waist. When carrying, maintain a good power grip and keep the weight as close to your body as possible. If you need to navigate stairs with a patient, a stair chair should be used to assist the EMS crew in moving the patient. Sometimes, however, given the patient's mental status or condition, a stair chair cannot be used and the patient must be carried up or down stairs while in a supine position. Assuming 2 providers can carry the patient, one should be positioned at the head and one at the feet, with both providers facing the patient. If the patient is being moved downstairs, the person at the feet will go first and will proceed slowly and carefully backward down the stairs. This person should have a spotter to assist, as this provider should avoid twisting and turning to see where he or she is going. Inversely, if going upstairs, the provider at the head of the patient should go first, walking backward up the stairs, and the spotter should be behind this provider, assisting him or her as that provider proceeds backward up the stairs. If the stairway is wide enough, it would be preferred for EMS providers to be at the corners of the longboard or cot, requiring at least 4 providers to move the patient up or down the stairs. Sometimes it may be necessary to actually slide the person up or down the stairs while on the longboard. If that is done, it is absolutely imperative that the crew ensure adequate, proper, and ongoing control of the patient and the longboard to avoid an uncontrolled descent down the stairs. Utilizing a rope configuration may even be necessary in some extreme cases. Again, these are just some guidelines and suggestions on lifting and moving patients, as circumstances can vary considerably from call to call and situation to situation. Other means of lifting and moving patients may be required. Also remember your previous EMT training as well. Lifting and moving patients is indeed a basic skill for any EMS provider. Again, the further away a weight is from your center of gravity, the more force it takes for you to lift or hold that weight. The more force you must exert over a period of time, the faster your muscles will fatigue, and the more fatigued you are, the more prone you are to potential injury. This is important to remember when having to reach away from your body to lift, move, or carry a patient, equipment, or some other object. Whenever possible, try to have the person or item you are about to lift, move, or carry as close to your body as possible. If necessary, reposition the object or yourself to avoid having to reach out from your body any further than necessary. When reaching, keep in mind the tips we already discussed regarding body positioning for lifting, moving, and carrying people and objects. Keep your back in a locked position and avoid twisting or turning while reaching. If you find it necessary to reach over your head, do not hyperextend, lean back from the waist while reaching. One of the most common reasons why an EMS provider needs to reach is because he or she needs to log roll a patient. If you need to log roll a patient, start with being as close to the patient as possible. Reach by leaning from the hips, not the waist, keeping your back straight. Try to use the muscles in your shoulders rather than those in your back to roll the patient. If you find yourself in a position where you need to push or pull something, it is preferable to push rather than pull if you have the option. When pushing, try to keep the item you are pushing somewhere close to the height of your torso, between the shoulders and waist. If the item is below your waist, then kneel or squat down if you can prior to pushing. When pushing, keep your elbows bent with your arms close to the sides of your body. If you need to pull, try to keep the object being pulled at the height of your torso, between your shoulders and hips if you can. Also try to keep the object close to your body, keep your back straight, and keep your knees slightly bent. From this point forward, we will now focus specifically on patient movement. In particular, we need to recognize 3 categories of patient moves: emergency moves, urgent moves, and non-urgent moves. If you have a patient who is in immediate danger of greater injury or harm, or the rescuer, him or herself, could be in immediate danger given the patient's location, an emergency move of the patient is warranted. Some examples of circumstances in which an emergency move may be necessary includes instances of fire or danger of fire. There is an exposure to explosives or other hazardous materials. When it is not possible to protect the patient from other hazards on a scene, such as a hostile crowd, unstable terrain, extreme weather, or uncontrolled traffic on a roadway. If the patient's location or position impedes the delivery of life-saving care, or when the patient must be moved in a vehicle to provide rescuer access to other patients in the same vehicle who need life-saving care. There are 3 routine emergency moves that EMS providers should know: the armpit forearm drag, the shirt drag, and the blanket drag. The armpit forearm drag is used when the patient is on the floor or ground. The provider approaches the patient from the back, inserts his or her arms underneath the patient's armpits to the point where the patient's back is against the provider's chest, and crosses his or her arms over to grasp the patient's left forearm with the right hand and the patient's right forearm with the left hand. The provider can then pull the patient backward along the ground or floor, essentially dragging the patient out of the hazardous area. The shirt drag is just as it sounds. The provider uses the patient's shirt to drag him or her away from the area of danger. To effect this move, it is commonly recommended to bind the patient's hands or wrists together, possibly with a cravat, cling, or some other type of implement to help keep the patient's shirt on during the maneuver without the arms flopping up or around. The provider then grasps the neck and shoulder areas of the shirt, resting the patient's head on his or her fists, and pulls the patient using the shirt. It is important when performing a shirt drag for the provider to ensure the patient's shirt is pulling from under the armpits and not around the neck. If the shirt is pulling around the patient's neck, the provider should reposition his or her hands and/or the shirt as necessary to alleviate pressure on the neck and transfer the force of movement to under the armpits. Given the stresses and forces involved in performing a shirt drag, it is typically not recommended that a shirt drag be performed if the patient is wearing a t-shirt or other light fabric shirt. The shirt drag works best when the patient is wearing a heavier shirt or a shirt with more substance to it. Lastly is the blanket drag, where the patient is rolled or placed onto a blanket or other durable fabric that is large enough to accommodate the patient, like a coach or a beach towel, and the provider grasps and pulls the blanket to move the patient. An urgent move is precipitated by just that, some type of urgency. While the patient may not be in a hazardous position that would prompt an emergency move, an urgent move is no less critical for the health and safety of the patient. Moving a patient from a bed to the hard surface of the floor so CPR can be performed is an example of an urgent scenario that could give rise to the need for an urgent move. Other examples include a patient with an altered mental status, inadequate breathing, or shock. Another case where an urgent move may be required is at a motor vehicle collision where a patient presents with one of those previously mentioned indications. In such a case, rapid extrication may be performed. There are also cases where the provider may need to access another person in the vehicle, and someone else who is in the way may be asked to self-extricate, step out of the vehicle, to provide rescuer access to the other person with an altered mental status, inadequate breathing, shock, major bleeding, or other significant and life-threatening injuries. When performing an urgent move, the provider should keep in mind the proper body positioning suggestions mentioned earlier in this presentation regarding lifts, carrying, moving, and reaching. Use your legs, not your back. Avoid twisting while lifting or moving the patient. Keep your head, neck, and spine aligned if possible. Use a power grip, and so on. Also keep principles of patient protection in mind. If the mechanism of injury is such that you need to be concerned with spinal immobilization, do what you can to minimize movement of the head and neck by quickly applying a C-collar or use a blanket to create a horse collar if time permits before performing the urgent move. If the patient is a victim of significant trauma of an extremity, try to minimize movement of the extremity when performing the urgent move. Maybe you can rapidly splint before the move, or you have enough providers on the scene so that one provider can hold the extremity while the other providers perform the urgent move of the patient. Try to minimize additional harm to the patient when performing urgent moves. In the case of moving a patient from a bed to the floor to perform CPR, the patient should be lowered to the force gracefully and carefully. Be aware of the patient's head and do not allow it to strike the floor with force. Again, many of these moves were taught or should have been taught to you in your initial EMT education and training. The principles are still the same, and you are encouraged to practice these moves if it has been a while since you performed them. Lastly are non-urgent moves. These moves are used when there is no immediate threat to the patient's life, wellness, or safety. As an EMS provider, you will have time to perform these moves and therefore can stop and think, if necessary, to determine how best to move the patient without causing or increasing discomfort or pain. In many cases, the patient will be able to assist you with his or her own movement. In other cases, you will want to use a piece of equipment such as a lift belt, stair chair, backboard, scoop stretcher, basket stretcher, or flexible stretcher to assist with the move. Some routine scenarios in which non-urgent moves may be necessary include a direct ground lift where the patient does not have a suspected spine injury. Maybe the patient has limited mobility, has fallen, and simply cannot stand back up without assistance, or you need to transition a patient from the floor to your cot. In these cases, several providers essentially cradle the person in their arms to perform a lift from the ground to the cot, a chair, a bed, or wherever the patient needs to go. An extremity lift is somewhat similar, only the patient is not cradled. Rather, the providers grasp the patient's arms, wrists, and under the knees to perform the lift. This kind of lift should not be performed if the patient has a suspected extremity or spinal injury. When using a direct ground lift or extremity lift, the providers must be aware of the patient's head. If the patient cannot hold his or her own head up, then a provider must be there to support the patient's head. Additionally, these lifts are easier with lighter patients. As the patient's weight increases, these lifts require additional rescuers and become more difficult to perform. In many cases, it may be easier to use a longboard or scoop stretcher to assist with lifting these patients. Another type of common non-urgent move is one designed to transfer a supine patient from a bed to the stretcher. The direct carry method is similar to the direct ground lift, only the patient is being picked up from a bed rather than the floor. The providers are still cradling the patient in their arms when performing this move. Another popular move technique in these scenarios is to use the draw sheet method, where the crew simply uses the sheet upon which the patient is already lying to move the patient. This same type of lift and move is often performed at the hospital when the crew must move the patient from the cot to the hospital gurney or bed. Simply take the sheet that is under the patient, pull it taut, and bundle up the edges, and use the sheet to lift the patient onto the gurney or bed. As always, regardless of the type of lift or move being performed, always keep proper body mechanics and positioning in mind to minimize your risk of injury. That completes this module on workforce safety and wellness principles related to the lifting and moving of patients. You should now be able to differentiate proper from improper body mechanics for lifting and moving patients in both emergency and non-emergency situations. As mentioned previously, the information in this chapter is based upon initial EMT education and training material. If necessary, go back to review that information along with your own agency's protocols related to lifting and moving patients. This presentation was prepared by Waukesha County Technical College in Pewaukee, Wisconsin, and is distributed with an Attribution, Non-Commercial, Share-alike 4.0 International Creative Commons license. Copyright 2019 Waukesha County Technical College. For information on WCTC's numerous fire and EMS educational offerings, please visit us online at wctc.edu.